Have you ever considered looking inside your patient's body? Have you ever wondered how musculoskeletal ultrasound could elevate your physical therapy or medical practice? And what if you could instantly visualize soft tissue injuries and improve both clinical outcomes and also reimbursements? Are you ready to move beyond manual physical therapy palpation into the diagnostic future of physical therapy? Well, hello, and welcome to another episode of Your Practice, Your Money, where clinical success meets financial freedom. I'm Dr. Dimitrios Kostopoulos, your host, and today we are diving into one of the most exciting advancements in physical therapy and medicine: musculoskeletal ultrasound. Whether you are in a private practice or part of a multidisciplinary clinic or a hospital, MSK Ultrasound can help you diagnose injuries with greater precision, improve patient outcomes, and create new revenue stream for your business. Joining me today will be Dr. Mohini Rawat and Dr. Konstantine Rizopoulos, and they will together walk us through the practical steps physical therapists and other medical professionals need to take to start implementing this powerful technology in your own clinics. From training and equipment to billing, coding, and clinical application, this episode is packed with insights you can use right away. So let's get into it. I would like to welcome you all to another episode of our 13-week series, Transforming Physical Therapy with Diagnostics. This is a 13-week educational series that promises to elevate your patient outcomes and also expand your services to thrive in a changing physical therapy landscape. I want to remind everyone that for previous episodes, as well as resources that you can find about today's presentations, you can go to discoverdiagnostics.com. And a big reminder to all of you to watch my new podcast, Your Practice, Your Money, where clinical success meets financial freedom. And you can go to yourpracticeyourmoney.com for information and episodes there. Today, we are going to discuss about how to implement MSK ultrasound for the physical therapist and the medical practitioner. And we have with us two business partners of mine and colleagues and some of the top authorities worldwide in the area of MSK ultrasound. And I'm going to start introducing Dr. Mohini Rawat. She is the female in the company here among the three of us. Dr. Rawat is the director of the MSK Ultrasound program of the American Academy of Musculoskeletal Ultrasound and the HADS Fellowship program. And she is also a senior faculty and mentor on that program. And introducing you also Dr. Konstantine Rizopoulos, who is the co-founder of Hands-On Diagnostics and also the assistant director of the MSK Ultrasound Studies program. But before I put them in the spotlight and ask them to discuss today's topics, I want to just mention real quick this chart that I have shown you in the past. This chart shows basically For the most typical and frequent musculoskeletal type of diagnosis, what are the sensitivities of the various special tests that we do, and what the sensitivities can be of diagnostic testing, such as electromyography, musculoskeletal ultrasound, but also MRI? It is evident, as you can see here, that in a case of a rotator cuff tear, the NEAR test has only about 79% sensitivity, pretty similar to the Hawkins-Kennedy test, while musculoskeletal ultrasound sensitivity can be 92%, very similar, if not identical, to the sensitivity of an MRI. And specificity, actually, as you can see, of the NEAR test or Hawkins-Kennedy is at the 53 or 59%. Musculoskeletal ultrasound and MRI are comparable in both sensitivity and specificity. There is one major difference, or more than one major difference, that MRI is a static image test, pretty expensive, and not at the point of care. While musculoskeletal ultrasound provides mobility, you can diagnose problems and visualize problems while the limb is moving, while the tendons are put in tension, and it is much less expensive, and you have it in your clinic. You perform it. You don't need to send the patient anywhere to get the test done. There are many clinical uses of the MSK ultrasound. You can use it as a joint ultrasound, neuro ultrasound. Of course, ultrasound at a clinical setting can be used for pelvic floor also, and can be used for muscle recruitment, feedback, neuromobilization techniques, and even in a physical therapy setting for dry needling, for visualization, and also even visualization of the EMG needle. Also, if this is a physician who is watching this episode today, or you are working with a physician, you can use this technology to help guide aspirations or injections. So it is very important to mention that physical therapists are recognized among the accredited professionals to perform musculoskeletal ultrasound, and they are able to become board certified by taking the RMSK certification exam. So with that said, I turn it over to our guests. I'm going to start with Dr. Rawat. Mohini, give us an idea about how MSK ultrasound does fit within the rehabilitation professions, the musculoskeletal professions, and where we are right now with this type of technology.
Sure. I think my presentation complements with the information that you just presented. So I'll just first share the slides. And so we talked about shoulder and some special tests, and I have a similar slide comparing what the special tests that we usually use. I would say special tests are not that special. Looking at the sensitivity and specificity numbers of these special tests. So let's first talk about ultrasound, some basics. You may already know a little bit about ultrasound, but I'm just assuming that, at a very basic level, what is ultrasound and why we use it. So it's one of the most commonly used imaging modality worldwide. It uses sound waves, which makes this technology the safest imaging tool available out there. It's safe, it's reliable, it's non-invasive, and it's portable. You don't need a special setup wherever you practice, whether it's a community work that you do, or you travel between different locations, or maybe you have a very big practice and you have to move this machine one room to another. It is a portable structure, a portable unit, and it can be moved wherever the patient is and wherever you think it suits its purpose. So we use sound to generate image, basically using a piezoelectric effect, which is converting mechanical energy into electrical energy, and that generates the image. So when we look at the ultrasound, how it's being used these days, or how it's exponentially increasing, its use is increasing over the course, especially like, past 15 years, it's a revolution in patient care. There's one term that you may have heard called POCUS. POCUS stands for point of care ultrasound, which means it's used as an extension of your clinical exam. So POCUS is essentially use of musculoskeletal ultrasound imaging, but as an extension of your clinical exam. So you can be someone who is examining a patient and in your practice, and you use ultrasound to further guide the treatment, to further or accurately understand what's going on with the patient. Or maybe you work in emergency department and you need to like quickly assess which structure is torn, or where is the laceration, or which is the bleeding artery, or maybe you have to put a needle into a certain structure, maybe aspirate a fluid. So it's a revolution in patient care, and it can be compared, or it's being compared to stethoscope that was introduced in 19th century, because it is used as a stethoscope these days. If you go to emergency department, it's a smaller unit, so it fits in your pocket, and you can use ultrasound as immediate assessment, and it gives you information in real time, so you make those decisions, which most of the time inform the diagnostic process, but also help enhance the patient service by making your intervention more accurate. So like ultrasound guided interventions, whether it's injection procedure or dry needling or EMG placement, EMG needle placement, any type of invasive procedure where you have to introduce a needle, whether diagnostic or therapeutic, it becomes more accurate when you use ultrasound. So let's talk about shoulder pain. And we know like shoulder pain is a very common complaint, why many patients present to a physical therapist or physician. It constitutes about 4.5 million visits per year in United States itself, and it's, the number is much bigger worldwide. Now, if someone presents to you with shoulder pain, there can be different sources of that pain. And majority of special tests, when we use them in isolation, they lack diagnostic accuracy. And this table here shows us the sensitivity specificity. Again, this is the same information that was presented earlier. And you can see the numbers are, 50s to the highest 60s, and they improve or they get better when you use them as a cluster. But I will further say that whether even if the test or the cluster has higher sensitivity and specificity, it still does not tell you the structure that's causing the problem. So for example, we have Hawkins-Kennedy, we have NEAR test, and you can see the sensitivity, specificity, and accuracy numbers right here. Now, let's say with the special test, it's an impingement syndrome. But what's getting impinged there? You don't know that just based on special tests. For that, you need imaging. So now, if you look at ultrasound imaging and what the sensitivity specificity is, when you compare to here, they are using, different gold standards. So if you compare it against MRI or surgery or arthroscopic finding, you can see it reaches 100%. So it's like, 90 to 100%. So it's a much sensitive and specific test compared to the special tests that we routinely use in clinic. Now, let me give you a visual picture of what it means when you actually use. We can all talk about, okay, sensitivity, specificity, but we all know we have those favorite special tests. We always use them for our examination. But when you start using ultrasound, you will not go back doing things the old ways. But let's say someone presents with shoulder pain and they are not able to elevate the shoulder. Now, there are different reasons why a person may not be able to elevate their shoulder. And in many cases, these special tests or clinical exam can be inconclusive, because the first thing that comes to mind is maybe there is some type of tear or rupture. So the structure responsible for elevating the shoulder is likely torn. What if this patient also has like a lot of pain, and they have some protective spasm? Do you think can you reliably use these special tests in that scenario? So let me give you some examples of what you may see in these patients. So if the patient presents with inability to elevate the shoulder, there are different possibilities or different structural sources. So this is ultrasound image just to orient everyone what we are looking at. So this is, we are talking about normal appearance right here. So that's acromion, this is a greater tubercle, and that's supraspinatus. So we place the probe on the anterolateral aspect of the shoulder, and we watch this area, which is where we expect the impingement is happening, or there is some type of pathology which is restricting or not letting the patient to elevate their shoulder. It could be a bony problem, it can be a tendon problem, it can be a bursa problem, but this is where we find our answer. Now, this is how we check it dynamically. Now, remember, ultrasound is real time. So we check everything in static imaging, and we also add some dynamic. So this is acromion, aspirated tubercle, and this is the tendon right here. You ask the patient to elevate the shoulder, and this is what you see. The supraspinatus glides under the acromion, and then close to like 40 degree of elevation, or abduction or flexion, or a combination, you see everything nicely tucked under. So what's happening here is the tendon along with the overlying bursa is smoothly sliding under acromion, which we want it to happen. You know, when you elevate the shoulder and you have no restriction, you have no pain, this is exactly what we see there. This is normal dynamic motion or normal biomechanics of the shoulder or normal motion of the structures. Now, if someone presents with difficulty elevating, these are the scenarios. They may have a really angry bursa there. So you see this layer right here, it was not present in the previous example. This is a significant amount of fluid in the bursal plane. Now it's going to, first of all, it's angry, it's inflamed, right? So it's painful. And this is something extra sitting in that subacromial space. So it's going to cause a mechanical restriction there. It's going to resist that nice, smooth sliding of the supraspinatus in person. So that's one of the scenarios. Now, when this person elevates the shoulder, you can see this fluid spreading over the area, and it almost like becomes like a block, a soft tissue block against the acromion. So this is just a different view of the same bursal plane image. This is dynamic assessment where when you forcefully elevate the shoulder, can you see how that fluid is pulled under the deltoid? So that's going to restrict the movement and cause this fullness or restriction or pain or difficulty elevating or moving the shoulder. We may also see full thickness rupture of supraspinatus. So in this specific example, this is acromion, that's humerus, and you may notice that triangular structure that we saw earlier is missing. So this is another scenario where patient is not able to elevate the shoulder and they have rupture of supraspinatus. This motion, if you pay attention, looks different than the previous motion. Even if you have no experience, you know this motion in cineclip looks different than the previous example. And that's because we are seeing some compensatory movement here. So if you look at this clip, it looks like everything just moves lateral. There's no real joint play there. There's no real joint play because the structure that actually is responsible for joint play is absent there. So the patient is doing this lateral flexion of compensatory movement, some scapulothoracic movement, some lateral flexion of the spine to get some range of motion in the direction of elevation. Then we might see another scenario. Here, if you see this bright structure, that's a dense calcification covering the supraspinatus. I'm showing two planes of view, long and short axis. Now, this patient will also have the similar presentation. They will have difficulty elevating the shoulder, a lot of pain because it's a dense calcification which is covering the entire supraspinatus. So again, this is going to be like inflammatory or like angry shoulder, but at the same time mechanical restriction because of the calcium being present there. This is another example. So here, I hope that with this, we have a good idea of like different structure that we can study with ultrasound. So it's good to know like the sensitivity, specificity for different diagnostic tools or special tests that we have. What does it mean when you actually see this patient? We can say, okay, ultrasound is excellent at 90% or 100%, but these real life examples will give you more information because you can get, this conveys how ultrasound informs the diagnostic process or to get more accurate information so you can understand what's exactly going on, what is the structure responsible for the patient's discomfort. At the same time, we pick up some incidental findings which we should not confuse with what's going on. To summarize what I presented so far, I think ultrasound is a revolution. It has changed and it will change how we treat musculoskeletal problems, no matter if you are a physical therapist or a sports medicine doctor, a rheumatologist. It's being embraced by the entire medical community because of its safety, its portability, and its reliability. And the amount of information that we gain by not exposing patients to ionizing radiation with other imaging like X-rays or CTs.
Mohini,
So
thank you. And my goodness. And what is amazing is being able to see inside the patient's body the same technology that for years now, for decades now, exists where pregnant women are able to see the baby and the doctor to be able to make a diagnosis, same capacity now the healthcare providers who deal with the musculoskeletal system can see this. Also, it brings another important topic into play because unfortunately, we're dealing with a healthcare system where patients, you request to get from an insurance company physical therapy visits or any kind of visits or any kind of procedure, you get a denial or you get a limited number of visits. And the patients, especially those who cannot afford to pay out of pocket, they are on the shorthand of this, and their care and their life, their quality of life is compromised. And I believe that the musculoskeletal ultrasound technology can offer a significant help within a rehab, physical therapy, rehab, medical office caring for patients with musculoskeletal problems to offer solutions. So, Costa, I want you to start discussing first this very issue on what impact this can have, this technology can have in patients who come in within a physical therapy or medical practice.
Thank you very much for the invitation, first of all. And it is a phenomenal subject to talk about. And one of the reasons that Dr. Rawat, myself, Dr. K, the whole idea of what we represent came about, it's because of the healthcare system and the concept of the failed physical therapy. What is that? Okay, say you have a patient that, or a client, they have an injury, right? They did something and they feel pain. It can be chronic, it can be acute, but they have pain, and it's about time for them to seek attention, right? So they go to their doctor maybe, or to ER, or they come to see you as a physical therapist. And while you're examining them, you decide that this patient needs an MRI to be able to find out more about their problem so we can continue care or identify what kind of care they need, right? I mean, all of us in what we do have come to a kind of dead end that we want that extra help, that extra understanding of a condition so we can be able to put together a plan of care. So we request an MRI. And what happens most of the time? Most of the time, what we get a denial, right? I mean, denial after a request for an MRI, it's always the case, at least in my career, that's what I'm getting. So what is the doctor wants us to do, or even if it's us, right? What do? We start physical therapy. If the insurance says, no, 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 you're not going to get the MRI. You're going to go first for physical therapy. You're going to do 3 times a week for the next 4 weeks, total of 10, 12 visits. If you're not better, then I'm going to send you for an MRI. So they come to us. We start, like so hard work as we are and passionate about helping the community, right? And our clients. What do? We provide 3 times a week for the next 4 weeks. So 10 or 12 treatments out of their 20 visits per calendar year. This patient has only 20 visits for the whole year. So we did 8 up 10 of them. And we realize after 10 visits that there's no results. The pain is still there. So what happens next? We go for an MRI. Of course, now there is an approval. And of course, the approval says that there is a rotator cuff tear, right? What happens? This is a significant rotator cuff tear. We cannot help it as therapists. They need surgery. They go for surgery. What's the result? They come back to us for treatment. You have only 10 treatments left. How much you can do in 10 treatments? These patients, they might need few months before they go back to normal. So you can see that we're going through that failed PT scenario, waiting for the system to approve something so important as an MRI to figure out what is going on with the patient, right? With our patients. And by the way, our reputation is at stake here. Because at the end of the day, you provide treatment, you cannot make them better. Who is the bad person? Usually the physical therapist, unfortunately. In any case, that was one of the major issues that makes us, that we decided as a company here and as professionals to start looking into other ways of doing business that it will help the patient to begin with, and it will help us to be better in what we do and provide an accurate treatment. How do we do that? With the use of ultrasound. Interesting enough, I have here a slide, that talks about accuracy of ultrasound. The ultrasound is missing from there compared to an MRI. And as you can see from here, it is so similar. Dark orange is the MRI, light orange is the ultrasound. I mean, just looking at this, sensitivity and specificity, so similar, okay? So nobody can tell you that MRI is better than ultrasound, especially for the rotator cuff tear, okay? Ultrasound can do sometimes even better job than MRI when it comes to rotator cuff. And that slide next to it, you can see the difference in cost. I mean, MRI can cost up to $1,400 or up to $4,000, depending on the insurance, right? Ultrasound is what, $140, $150? That's how much we get paid for an ultrasound if we do 2 joints, right? So it is really cost effective for the system. It is cost effective for the client. Even if the insurance cannot approve an ultrasound, who can do it for them? It's so much less than any other exam with the same or even better results. But the beauty here is what? The beauty is that if they come to you the first day and you don't know what exactly is going on with this joint, with this rotator cuff, with that shoulder, or any other joint, you have the ability right there and then to do the ultrasound so you can be able to see what's happening with the joint. And by the way, you might not have any problems. It might not be the shoulder at the end. You might have shoulder pain because of your neck. That step, though, of knowing that there is nothing with the shoulder as a joint, it will help you to focus in a different area. So from that point of view, it is extremely important to know that. For instance, here I have like a small video of what is an abnormal rotator cuff. What you see right here, it's a supraspinatus in a long axis, right? Great tuberosity, that's the footprint of the tendon, that's the articular side, and this is the tendon attached on the great tuberosity, deltoid on top, that's a normal supraspinatus. And now take a look at this. Okay, I'm going to play the video, and you try to focus in those 2 images, one and the other. And what you see here, you have like a rotator cuff tear. And as you can, I'm going to play the video on my own. I'm going to stop it here. So I'm going to take you from the right here. This is the great tuberosity. You can see already there is a detachment. You can tell there is a tear. Of course, it's not appropriate to talk about what kind of tear at this point, but you can see even signs of tendinosis. You can look at this, how bad it is, this tendon. So look at the normal, look at the abnormal. You can have access to this information in the first visit without waiting for you to go through the MRI or anything else to get information, okay? The same thing in a short axis. That's a normal tendon, supraspinatus tendon. We call that the tire on the rim, right? The rim being the bone here, the humeral head. This is the supraspinatus, and on top of this, the deltoid. And again, the same problem, you're going to see it now in a short axis. The humeral head, you can see the cortical irregularities, and right there you can see the tear of the supraspinatus, that being lateral, that being medial, okay? So this is the information that you get immediately without waiting for any MRI to come to you. This is like talking about tendons and ligaments. This is another comparison between MRI and ultrasound. This is the pulse sensitivity, 0.91. And you can see here, you know, the squares here, the how the ultrasound falls based on the tendons, specific tendons. Very, very high sensitivity in with the use of ultrasound. And for instance, this is the MCL now. Look at the normal MCL and look at here a torn MCL. I mean, this is two problems. You have a torn MCL and you have also fluid on the medial recess of the knee that comes from the sublateral bursa. But right here, you can see how the ligament of the MCL is torn, and that's what normally looks like. So again, an ability to know what the problem is right away. This is ultrasound versus MRI when it comes to the knee. Circles are MRI, squares are the ultrasound, and you can get an idea of different ligaments or tendons that ultrasound can be in a better position than the actual MRI. Bone stress. I mean, yes, we're not looking for fractures on bones, but you know, if it's there, you can see it. You cannot miss that. And recently, I had a case with a person with a negative X-ray. 2 months later on, pain there, like lateral malleolus pain. They came to me, and the pain was present. I mean, the fracture was present. That's his normal side. Look at his abnormal. 2 months after, nobody did anything about this person. Negative X-ray. But you can see the fracture in there. You have the ability with the ultrasound to be so much more effective under the POCUS idea that Dr. Rawat explained, the point of care ultrasound, to know on time what's happening with the patient, so you can build an appropriate treatment plan.
Thank you, Costa. This is very important, especially when it makes a difference, when this simple diagnostic procedure can make a difference in the entire healthcare system and help patients primarily. But the concept of appropriate education for this technology, okay? So, and I'll tell you the reason I'm bringing this up is because I have heard horror stories. And what do I mean by that? I mean that a friend of mine who is an orthopedic surgeon, he does shoulders. He essentially received an MSK ultrasound testing from a professional, and the report that was produced was sent to that orthopedic surgeon, a friend of mine, and it was horrific. It was disgraceful based on the imaging that was produced. So then the orthopedic surgeon, and this is where the strange thing lies in, that my friend called up that professional and asked that professional how that professional received their education on MSK ultrasound. And the answer was through YouTube videos. Okay? So we have this phenomenon in the education front where you have people where they may just take a weekend workshop or watch a video or even take programs that even have the title a fellowship program, and those programs are simply classroom programs with no mentorships, no report reviewing, no direct guidance. I'm kind of equating that to learning, let's say, for a physical therapist, if we talk of physical therapist, learning manual therapy without practicing it, just by observing someone doing it and never practicing it, never receiving mentoring on the process. Or having a surgeon who, they observed the surgery and then started practicing surgery without getting a residency. It's not possible, right? Let's talk about that a little bit. What difference does the true educational mentorship from a true fellowship, what is the role that it plays in the education process?
All of us here, the three of us here, are very passionate about the diagnostic tools, EMG and ultrasound, I would say, together. But because we are talking about musculoskeletal ultrasound, it's a great tool in the hands of skilled clinician. So now, who is skilled clinician is really up to you. You can really take the tool, and sometimes we confuse technology to. Although we are using technology, and the technology is great, giving us these great images, and there are some technical advancements that the images are much crisper, but it largely depends on the skill of who is obtaining or acquiring those images. And do you understand what's going on there? Because you can also do a lot of harm here if you don't understand those images. You can make something look bad and give the patient pathology that they don't have, or you can completely miss something that should not be missed. Like, the great example that Dr. Rizopoulos presented, fracture of that site, it needs a different management. And if you miss that, it can be really like a terrible thing for a patient. Yeah. I'm just like lack of being less sophisticated. I would say like garbage in, garbage out. So if you don't really take it seriously and you don't really pay attention to the skill, it's not an iPhone or electrical device or AI or Alexa that's going to do everything for you. You have to actually learn the skill. You can have the best machine out there, the labor and the time, what you put in, you will see the difference.
Awesome. How the mentorship program of the American Academy of Musculoskeletal Ultrasound works?
So we have the most comprehensive fellowship program available out there, which is available for non-radiologists. And we take pride into that. Why we say it's most comprehensive is, other than having live in-person classes where we spend 75% of the time in lab, making sure that everyone learns the skill and they are mentored 100% of the time, they also are tied with a mentor as they're learning the skill. So we hold the hand of the mentee as they acquire the skill. They are novice. They just learn the didactic information. Now they're learning the scanning protocol. They're submitting those reports that are being reviewed. They also have a building time one-on-one mentorship. So your practice may be more focused on a certain type of patient population or a different type of a specific set of joints. We customize the fellowship based on what your practice is. At the same time, making sure that you are learning everything that you need to become a fellow in musculoskeletal ultrasound. We also have advanced modules built in there. So there is a lot of mentorship built in, which is customized to the mentees.
Thank you. That's awesome. Kostas, when we are mentoring students, how do you see, how soon can someone become an expert, or how soon can someone produce acceptable images, and how important it is for them to be in a fellowship program that provides mentorship so that when they bill insurance companies, they can have a reliable product?
It's important to say that the fellowship and the whole training that we do, it came about because our own training more than 10 years ago, it was very, very basic, right? I mean, I got like a specific 4 days training on ultrasound from a company, somewhere in the United States. And when I came home again, I was like, I don't know nothing. It was totally beautiful, for days, a lot of information, but there was no way for me to apply them. So the way I started learning was studying myself. I was self-taught in a way how to recognize, first of all, what normal is on tissue, because to really learn ultrasound, you gotta know what normal looks like before you decide what abnormal will look like, right? So this is important. And again, when we start training our students, we go through that normal, and we encourage for them to keep doing normal until they build those images of what norm is in their mind, so they know when they see something that it's not normal to claim it also. So that takes few months. Okay, it takes few months before you're able to really start feeling that you're comfortable with, let's say, shoulder. And the way I approach the students is like, you don't have to go to all 6 joints right away. Just pick one, focus on that, learn that joint, spend like a month or two on that 1 or 2 joints, be familiar. In any case, in our setting, knee, at least in my clinic, knee is the number one, shoulder, and then you have ankle, elbow, and then wrist and hip. Okay, so shoulder and knee, it's the number one thing that I make sure that these students are very familiar with. And then the more you recognize what normal is, and again, if a tendon has a problem, whether it's in the shoulder or in the knee, you can see the problem.
Thank you. If you are a physical therapist or other healthcare professional who is interested to get into this, find more resources on discoverdiagnostics.com, and you will have their links to see both the American Academy of Musculoskeletal Ultrasound and the HUDS organization. And those of you who are interested to listen to other topics, join us and subscribe in our weekly podcast, Your Practice, Your Money, where clinical success meets financial freedom. Both of you, Mohini, Kostas, thank you for joining us tonight. And the rest of you, have a great evening. Until next week, keep serving people and keep enjoying life. So that's it for today's episode of Your Practice, Your Money, where clinical success meets financial freedom. If you are excited about MSK Ultrasound and want to explore more resources, guides, and even training programs to help you get started, please visit us at yourpracticeyourmoney.com. And please remember to subscribe to our podcast on Spotify, Apple Podcasts, or wherever you listen, so you never miss an episode. And if you are watching this on YouTube, please click subscribe, because that helps us move up on the list of YouTube recommendations so other colleagues of yours can watch us as well. So we'll see you next week for another impactful topic that brings you closer to your goal of clinical success and financial freedom. Until then, keep serving, keep growing.